Good evening, everybody, and welcome to this 17th edition of Ortho-TV webinars. And I'm here today with Dr. Abhijeet Wahegaonkar. He is a distinguished hand and microvascular surgeon, and he works at Apollo Hospitals and at Sancheti Institute and Jahangir Hospital in Pune. So we are eager to hear about TFCC repair and the injury as such from you, sir. Welcome to Ortho-TV, sir.
Thank you very much, Dr. Sham, and it's indeed a privilege and a pleasure to be here with you to share a little bit about Tfcc repairs, cryomyopathic repairs, and I'm very grateful for the opportunity to be interacting with live audience across the world. So, and thank you for that glowing introduction. My task is to talk a little bit about TFCC repairs and understand the injury, the pathomechanics, and the different ways of dealing with this. For this particular talk, I'm going to stick to only acute injuries, and then maybe in another talk we can deal with chronic injuries of the triangular fibromyalgia. So, what is it that we know about TFCC injuries? And I don't have any conflict of interest regarding this particular talk. So it was way back in 1771 that Dassault from France was the first anatomist and a great surgeon who recognized and described this particular entity and also recognized injuries to this particular structure and the problems caused thereby. But what is interesting is that it was almost in the 20th century, so almost three centuries later, that people started, or 2 centuries later, that people started recognizing this again in the fresh studies that were described by Palmer and Werner. And they looked at cadavers and they applied different forces and they came up with a classification that was very widely used until now, and it has been replaced with a newer classification with the advent of arthroscopy, and we'll talk about it a little later in this talk. So the triangular fibrocartilage complex, as they call it, is a major ligamentous stabilizer of the distal radioulnar joint and the ulnar carpus. So it's a link between the ulnar carpus and the distal radioulnar joint. With evolution, the DRUJ, or the distal radioulnar joint, has really evolved to be a very specialized joint. And it is because of this joint we are able to do a lot of prehension activities along with applying strength and force to what we do. And it is very interesting that we now recognize there are some anatomists and hand surgeons who now think that this should perhaps be called as a distal ulnoradial joint rather than the radioulnar joint, because the ulna perhaps has a greater role to play in prehension function than we admit or recognize. So what do we know about pain that arises from the distal radioulnar joint? So one of the disclaimers is that there are a myriad of causes that can be responsible for ulnar-sided wrist pain, and what we are talking about today is just one of those causes which can cause severe disabling pain of the ulnar side of the wrist. So the DRUJ pain characteristics are that it is a very common problem. It is a pretty disabling problem. If some of you have ever strained or sprained your wrist, and then if you're trying to, kind of put in screw with your plate, in your plate to understand, you realize how much weakness you develop. So it is a disabling problem. It is difficult to understand because of the numerous structures, and a lot of times ulnar-sided wrist pain is referred to as the low backache of the wrist joint. Pretty much like backache, there are so many causes for distal radial or ulnar-sided wrist pain, and hence it is difficult to understand. And because it is difficult to understand, it is also difficult to treat, and has very rightly been labeled as a black box of the wrist joint. And it is referred to as a low backache of the wrist, as I talked to you about. And in one way, it is a drudgery to deal with these problems. A little bit about the relevant anatomy of the Tfcc. So it is triangular in shape and it extends ulnarly um, to insert on to the base of the ulnar styloid and distally it inserts into the lunate through the ulno-lunate ligament and the ulno-triquetral ligament and the base of the fifth metacarpal. And then radially, it arises from the rim of the sigmoid notch or is inserted onto the rim of the sigmoid notch of the lunate fossa of the radius. So it is like a hammock, all right? It's like a hammock that kind of not only supports the ulnar carpus, but it also forms a link between the ulnar carpus and the distal ulna. So these are cadaver dissections that will highlight what we now recognize as a distal component and a proximal component of the Tfcc. The proximal component has got Sharpie's fibers and a very, very solid attachment to the base of the styloid process of the ulna, and that kind of stabilizes the distal radioulnar joint. Whereas this particular aspect of the Tfcc forms a gliding surface for the ulnar carpus to glide on and kind of provide support to the ulnar carpus. And this is one specimen where we have reflected the Tfcc off. So this is the head of the ulna. This is the part that articulates with the sigmoid notch, this is the head of the ulna, and you can see the dorsal and the volar radioulnar ligaments, which form a nice, solid kind of a peripheral rim with a thin intra kind of a portion between the two, the dorsal and the volar aspects, and then this is the part which is inserted onto the radius. So it is a triangular structure, and the central part is thin and avascular, pretty much like we see in the meniscus, and often tears in this part cannot be repaired and are not repaired. Here is a fetal wrist in the coronal section with histopathology specimen. We've done a H&E staining, and you can see the deeper or the proximal portion of the Tfcc, which has got a completely different structure histologically as compared to the distal part. The proximal part has got Sharpie's fibers that is inserted onto the wound directly. So this is just to highlight the different parts of the slide, the Tfcc and the styloid. So having understood the anatomy of the Tfcc, let us understand the functions of the Tfcc. So the Tfcc provides a continuous gliding surface across the entire distal facet or distal face of the two forearm bones for flexion, extension, and translational movements. So this translation can be in the coronal plane and in the sagittal plane as well. It provides a flexible mechanism for stable rotational movements of the radiocarpal unit around the ulnar axis. It cushions the forces that are transmitted through the ulnar carpal axis, so it has a tamponade kind of effect, and it solidly connects the ulnar axis to the volar carpus. So these are very kind of a bird's eye view of the functions of the Tfcc. And now, how does a DR function as a unit? Understand that the distal radioulnar joint is a load-bearing joint. So, if you were to look at your wrist joint in this particular position and you're trying to lift up something, so say for example, I'm lifting this glass up, so the gravity is pulling the weight towards the floor, whereas my ulna is the only counter support or the counteracting force to stabilize the radius against the head of the ulna and the gravity. So the wrist joint or distal radioulnar joint is a load-bearing joint. All right. So this is one of the key or the fundamental aspects that you need to understand when you are dealing with distal radioulnar joint problems. The load transfer is from the hand onto the radius to the humerus to the humero-ulnar joint, while the ulna is stabilizing this entire articulation. And then besides doing this, it also allows for pronation and supination. So these are the primary functions of the Tfcc. And this particular schematic diagram will show that as the radius rotates around the head of the ulna, the Tfcc components either relax or stretch. So it is like the reins of a horse, and this has again been very detailed studies have been done and has been studied in a great detail, but this is beyond the scope of this particular talk. We can talk about it at a later date. You can see that apart in pronation, the volar aspect of the Tfcc stretches out, whereas the dorsal aspect kind of shortens. It is equidistant, or the length is equal in mid-throne, whereas in supination, the dorsal aspect stretches out and the volar aspect of the Tfcc kind of tries to pull everything together. So what is the problem when we see people with Tfcc injuries? So injuries of the Tfcc present with underside wrist pain and are frequently associated with some kind of clicking. Torn Tfccs account for almost 35% of the injuries that we see in distal radius fractures, and more so in extra-articular fractures. You can see that almost 50%, so 1 out of 2 fractures of the distal radius that are extra-articular will have an associated Tfcc. Now, the extent of the injury might vary, and then what we need to do for those injuries is incumbent upon what we have done with the radius and vestibular problems that may be associated. However, there is no correlation between fractures. There's a lot of times people ask, what if there is a fracture of the understriated? And we'll talk about that at a later date, or maybe later in the talk, as to how you deal with understriated fractures. There have been, again, very recent and very nice studies that have come out of Mass General and some studies from Canada that now say that not all understriated fractures need to be fixed, and there is kind of an algorithm as to how we go about it. So patients with torn Tfcc, these are cadaver studies, we need not belabor too much on this, but ulnar variance does play a little bit of a role in the incidence of injuries. Again, another cadaver study that was performed by Stephen Vegas and Nikic in 1978 and 87 respectively, where they found that after the 5th decade, most Tfcc is already degenerated. So you have to differentiate degenerative tears from traumatic tears. That is what this slide is highlighting. So how do Tfcc injuries occur? They are usually because of falls onto pronated hyperextended wrists. Well, there's a distraction force that is applied to the volar forearm of the wrist, and there are distal radius fractures. So these are the 3 types of pathomechanics or forces that will cause injury to the Tfcc. And this is a very interesting slide that I would like to share with you, that with normal loading, that is to say with the wrist in neutral, 20% of the forces are transferred through the DRUJ, whereas 80% of the forces are being transferred through the radius. However, when there is ulnar deviation of the wrist joint, this entire load transmission changes to 80% through the DRUJ and only 20% through the distal radius. So you can imagine when you fall on to an outstretched wrist with some torque that is being applied, there is a very high likelihood that Tfcc gets damaged. So now that you know what the anatomy is, what the pathomechanics are, what the clinical presentation is like, so you know that from your history there is a Tfcc problem, you go about documenting it or ascertaining your diagnosis with physical examination. So what are the physical examination methods? So obviously the history, like I said, includes underside wrist pain that is frequently associated with clicking, the history of a fall or a trauma, and or mechanical symptoms that improve with rest and worsen with activity. So if you ask a person, does your pain increase with lifting weights while you're driving, while you're doing interesting activities, they will usually admit that they have increased pain while they're doing such activities. So clinically, there are certain provocative maneuvers that we use, such as the allotment test, the shuck test, and the shear test that will help you ascertain your diagnosis. There is something called as a grinding or a clicking test. You also look for weakness with a Jamar dynamometer. There is a difference in the grip strength of both sides. The ulnar deviation of the wrist joint with the forearm in neutral produces ulnar-sided wrist pain and occasional clicking. And then there is a shucking test where you demonstrate or you put into evidence instability of the PRUJ. Then there's something called the piano key sign, which is prominent, and there is a dilatable distal ulna when there is a full pronation of the forearm. Other signs to look for are the ulnar carpal sag. So when you look at the wrist like so, the wrist appears sublux, pretty much like in anterior cruciate ligament injuries. There is a posterior sag at the knee joint of the tibia or the femur. Likewise, when you have a Tfcc injury, the carpal sag, ulnar carpal sag can be seen. Also look for lunotriquetral ligament or interval tenderness, because very frequently people who have Tfcc injuries may also have lunotriquetral ligament injuries. Then you put into evidence a positive lunotriquetral allotment or shuck test, and at times if there is a rupture of the subsheath of the extensor carpi ulnaris, that causes the ECU to subluxate. So with gentle pronation and supination, the ECU will subluxate volar and dorsal, and that is again one of the signs of a Tfcc injury. So grossly, Tfcc is the old classification that was described by Palmer and Werner in 1989, is still used very widely. There is a type 1 injury, which is a traumatic event, whereas type 2, which is a degenerative process. And then there are subtypes to it, which is highlighted on this particular slide. So when you're talking about type 1 traumatic, type 1A is a central perforation. Remember that the central aspect or the central part of the Tfcc does not receive any vascularity, and hence it is not reparable. Type B or 1B is under aversion, with or without a sternal fracture. Type 1C is a distal allergen from the carpus. You remember I was talking about the ulno-lunate and the ulno-triquetral ligament. So that is where these injuries will occur. And type 1D is a radial allergen, so the radial insertion onto the rim of the sigmoid notch. These are 1D. Again, they may be with a sigmoid notch fracture or without a sigmoid notch fracture. And then class 2 or type 2 are the degenerative tears. They're usually associated with the positive ulnar variance, which causes ulnar impaction syndrome. What that simply means is that the ulna is abutting against the lunate, and with time there may be either just a wear of the Tfcc, then it is called as class 2A. When there is a perforation, it is type 1C, and in between, when there is just some beneath the sigmoid. And then you have a Tfcc perforation with or without chondromalacia of the lunate or the ulnar head, that is 2D, and 2E is when there is ulnocarpal arthritis that has set in. Once you have done your clinical examination and your history taking, obviously now you want to proceed to radiographic evaluation. Usually we take standard films, the semi-pronated view, the semi-supinated view, dynamic, that is a clenched fist view, ulnar deviation view, or a loaded view, and obviously, yes, you would like to get an MRI done for most of these injuries. However, MRI is not the most sensitive or specific modality of investigation, but nonetheless, it's used very, very widely, and it is expensive. Another modality of investigation is to do an arthrogram, where you inject a radiopaque dye and you look for leak of the dye. So on the left-hand side of the screen, you see a normal Tfcc with no leak proximal, whereas here you will see that there is a leak of the dye on the right-hand side of the screen that is indicative of a tear of the Tfcc. Now, this doesn't tell you where the tear is, but it does tell you that there is a tear. And these are MRI pictures, representative images as to how a Tfcc injury can appear. And then, of course, an X-ray with such kind of an understudded fracture would also be suggestive of a Tfcc tear. So, when and how to treat these patients? And if you were to just summarize this entire talk, I could summarize it with this particular slide. When you have a stable distal radial ulnar joint with no instability, but there is just pain, you either splint the joint, or you can do injections, or you can do an arthroscopic debridement of an unstable flap, pretty much like you would do in a meniscal tear, central perforation or central tear. If there is an instability, obviously the joint needs to be stabilized, and this can be done either as an open or an arthroscopic repair and immobilization for approximately 6 weeks. And if it is a chronic tear with no arthritic changes, you would either do a repair or a ligament repair or reconstruction, usually a reconstruction. And then when sometimes there is an ulnar positive, you can do an ulnar shortening osteotomy procedure for these particular patients. So what are the recommended treatment options out there in literature? If it is a Palmer class 1A, you do an arthroscopic debridement. If you would have a 1B kind of an injury, you would do an arthroscopic repair. If it is 1C, you would do an open repair, and 1D, again, an arthroscopic repair. And let us understand what the parameters for treatment of peripheral Tfcc tears are. So like I told you, the old Palmer and Werner classification is now being replaced by something called as the EVAS, that is European Wrist Arthroscopy Society classification. This was devised by a dear colleague of mine by the name of Andrea Atze from Italy. And what we recognize now is these two components of the Tfcc. There's a proximal component and a distal component. Now, it doesn't take rocket science to understand that if only the distal component is damaged and the proximal is intact, there will not be any instability of the DRUJ. However, if there is a complete tear or a proximal tear, it will lead to instability of the DRUJ, and obviously there's going to be pain along with this instability. So here, for example, is a representative video of a patient under anesthesia, and you can see how significant the instability pattern is. I can ballot the ulna, and again I'll play this video for you. I can ballot the ulna, and you can see both in all rotations. I'm doing it in pronation, mid-prone, and supination, and there is a multi-directional instability of the ulna in all these rotations, which indicates that there is significant instability, so it may be a complete tear of the Tfcc. The gold standard for treatment of these injuries today is an arthroscopic repair, and we're going to talk about it in a little bit. We do these procedures under usually a supraclavicular block with tourniquet and an outpatient surgery. And this is a standard arthroscopic setup, and we use something. So the portals for wrist arthroscopy are in relation to the extensor tendons, so the extensor compartments. The most frequently used fluid portal is a 3-4 portal. What that means is that this portal is between the third and the fourth extensor compartment, and the working portal is a 6R portal, which is just radial to the extensor carpi ulnaris, and we'll just come to that in a bit. So here is a video demonstration. We suspend the arm at 90 degrees with counter traction. About 7 to 8 kilos of traction is used. And we use skin marking for the portal placement. Here I am using all the bony landmarks. I first begin with the distal tubercle, marking the distal ulna and the distal radius. Just ulnar to the distal tubercle will be the extensor pollicis longus, which is the third compartment. Then I mark the bases of the second and the third metacarpals. And now I know where the extensor carpi ulnaris is. I know where the fourth extensor compartment, which is the extensor digitorum communis, is. And that will now give me a rough idea as to where my soft spot of the 3-4 portal. Understand that the 3-4 portal is between the third and the fourth extensor compartment, which I have just marked here with my mark pen. Right. So once we have the 3-4 portal, which is your working portal, you bring in a hypodermic needle, and following the radial inclination and the radial slope, you pass your hypodermic needle inside, and you insufflate the joint with about 5 cc's of saline, and then you look for a back flow or a back pressure that the piston moves back, so you know that you're within the wrist joint. Understand that unlike other arthroscopy, we do not use saline for distension. The distension or the space for working is created by the traction that is applied. So once we are inside, you can see the backflow of the saline, and then you remove the needle and you make a very small incision, staying only to the dermis. You do not go any deeper because you do not want to damage the extensor tendons and the nerves just lying underneath the skin. A hemostat is brought in. The hemostat is your best friend because it helps you spread the tissues, make space and you just make a perforation in the capsule, you feel a pop, and then you bring in your scope or your cannula inside. Usually we use a 1.9 millimeter or a 2.7 millimeter arthroscope, but in this case, what you're seeing is a 1.9 millimeter arthroscope. And once you're inside the joint, you make your working portal or the 6R or the 4-5 portal under vision. All right. So now I am looking towards the under corner of the wrist joint. There's a lot of synovitis, as you can appreciate. You can see the lunate and the distal radius. I bring in a hypodermic needle to mark my 6R portal, which is just radial to the extensor carpial nares. Once we have verified the position of the needle inside, we bring in a I'm very sorry, this is the outflow portal, this is 6U portal, and now I'm going to make the 6R portal. You can see that there is synovitis out there, that is perhaps the tear. I'm now marking the 6R portal with the needle coming in here. This particular needle is through the 6R portal. So there are two needles. This is the outflow needle, the 6U. This is 6R. You see the veins and you try to avoid them. They make a very small stab incision, just like so, staying only to the dermis. You bring in your hemostat, gently spread the tissue, just like so, making sure that the nerves and the tendons are pushed away. And then you enter the wrist joint. And then you bring in your hook probe and you start examining. You can see that the trampoline test is being performed and the trampoline effect is lost. And here you can see a clear tear of the Tfcc. So the Tfcc is torn here. That is a peripheral tear. I can lift up the Tfcc along with my hook probe, and that indicates a tear. Then we bring in a shaver. And we freshen up the edges of the Tfcc in the capsule. We remove any synovium that is proliferated out there. Do a synovectomy. And what I'm doing right now is something called a suction test. As you stop your shaver and you just apply suction, you can see everything getting pulled into the suction tip, so the suction cannula. What that indicates is that the Tfcc is avulsed from its insertion onto the base of the styloid. So because there is no anchor to the Tfcc is getting sucked into the suction tip. So this is a test that was described from the Mayo Clinic. It is called as a suction test, another test to ascertain peripheral tear or a complete tear of the Tfcc. So once you have shaved and debrided your Tfcc, you bring in your sutures. We usually use a number 2 Ethibond because it's a very, very robust, very solid suture. It's a braided, non-absorbable suture. And then you bring in a loop of PDS, 20 PDS, through which the Ethibond is relayed to form a horizontal mattress suture. The loop is being retrieved with the hemostat, as you can see right now. And then after you have relayed the Ethibond, it forms a nice horizontal mattress. And I'm doing the same suction test while I'm pulling onto the Ethibond. You can see that the Tfcc doesn't get sucked into the suction as we have tightened the Ethibond. And then you tie a suture. So you're doing a capsular ligament repair. So this is for peripheral tears where the Tfcc is not completely avulsed. Now, if there is an avulsion of the Tfcc, like so in the schematic diagram, what you then need to do is you need to use suture anchors to anchor the Tfcc back onto the head of the ulna. So it is pretty much like a rotator cuff tear. Imagine if this were to be the rotator cuff, you would put in an anchor and get this thing back here. We'll just see how we do that in a bit. So all that we do is once we know, so this is the head of the ulna, we freshen up all the tissue out there, we remove the scar tissue, we create a footprint for the Tfcc to be attached. That's where the anchor will go in. As you can see, I'm removing all the scar tissue, and you can see this bare area which is at the base of the styloid process. And then once you have done that, you bring in your pilot hole making device and you make a hole out there. A trocar is used. You can see the fat bubbles knowing that you are in bone now. Once you've done that, you bring in your suture anchor, which is being inserted into the pilot hole that you have made, and your sutures are retrieved outside just like so. And once you retrieve your sutures, you make those passes through the dorsal and the polar aspects of the TFCC, as is being shown here. And then essentially what you're doing is this: you are repairing the TFCC back onto the unnerve using a suture anchor. The usual size of the suture anchor that we use is a 2.4 mm fast tack kind of a suture anchor, which is available with Arthrex. I do not have any disclosures regarding this presentation, but that is the one that we use very, very commonly. And this is the same patient that we started out with. Immediately after repair, you can see that it is very, very stable. We use a suture anchor here, arthroscopic assisted, and you can see how stable the DI. Here I'm testing in mid-tone and then in supination and inclination, and you can see that the DI is completely stable. The post-operative protocol is usually an above elbow splint to the forearm and supination, and there is a slight extension and another deviation for anywhere between 6 to 8 weeks. And then after that, we allow gradual active and assisted range of motion exercises. And at around 4 months after surgery, we begin strengthening exercises. But the patients are advised not to do any strenuous activities for a good 6 months after surgery. After which they're allowed to go back to their routine work as well as sporting activities, including contact sports. Here are some representative images about the function that can be expected after TFCC repairs have been performed arthroscopically. And you can see the grip strength being almost comparable on both sides. You can hardly make out the operative from the normal side. So in conclusion, arthroscopic repair, the indications are distal lesions of the TFCC with minor instability, and arthroscopy assisted osseous repair, that is to say, when you put in an anchor, the indications are when there is a foveal avulsion or a proximal tear along with major instability of the distal radioulnar joint. With that, I end my talk, and I would like to invite you to the Pune risk course. This is the first internationally endorsed risk course that we are conducting at Sancheti Hospital. On the 11th and 12th of August, we have a list of luminaries in the field of wrist surgery, both abroad, international as well as national. And we'll be covering the entire spectrum of the wrist joint, including arthroscopy, TFCC repairs, scaphoid injuries, distal fractures, and so on and so forth. And we have 4 credit points being accorded to us for this particular course. You can register by calling up Sancheti Hospital. You need to contact Mrs. Hina to register. Registrations are limited, and the delegate fees are very, very less. As you can see, 1,000 rupees for consultants, and for PGs and fellows, it is only 500 rupees. It's a 2-day course and is endorsed by the European Wrist Arthroscopic Society, the Asia Pacific Wrist Association, the Maharashtra Orthopedic Association, and the Pune Orthopedic Society, along with the Indian Arthroscopic Society. So the number for registration is given at the bottom of the screen. I'll just read it out to you. It's 982235333. Contact Mrs. Hina if you're interested in attending this particular course. And once again, thank you very much for the opportunity to be with you and talk to you about TFCC injuries. A special thanks to Dr. Ashok Sham for the opportunity. Thank you very much. Good night.
Thank you very much, sir. That was an excellent talk about TFCC injuries and its repair. So I have few questions regarding the same. So we can start with them, and then if there are more questions from the forum, we can take them.
Sure.
So about TFCC injuries, if you ask a lot of trauma surgeons who deal with distal radioulnar fractures, they will advise to ignore it rather than do something actively regarding that. Since most of us listening here are general orthopods, so what are your thoughts about that?
So let me make this as simple as possible. Imagine that you have a distal radius fracture with a suspected DRUJ instability. The first and foremost thing that you do is to fix your distal radius well. And once you've done that, you assess for instability of the distal radioulnar joint in all three rotations: pronation, mid-prone, and supination. So if in pronation it is unstable, in mid-prone it is unstable, but it is stable in supination, all that you do is you immobilize the forearm and the wrist, the forearm in supination with an above elbow slab or a cast for about 6 to 8 weeks. Majority of these instabilities will settle down without any further ado. However, if you have instability of the distal radioulnar joint, even in supination, which is the position of maximum capacitance and stability, sorry, here you would want to repair the Tfcc, and that can be done by just making a small knot. I'm talking about a scenario where there is just maybe no fracture of the ulnar styloid, or maybe just a chip fracture of the ulnar styloid.
Right.
You don't care much about the ulnar styloid fracture. What you're interested in is the Tfcc. So you just kind of make a small incision here, identify the Tfcc, and put some solid sutures through the Tfcc, and that would usually address the instability problem. Again, you immobilize in supination in an above elbow splint or cast for about 6 to 8 weeks. If there is a large chunk, if the styloid fracture is large, then you may want to fix it because the Tfcc is attached to the base of the styloid, and then if you fix the styloid back to the distal ulna, that would pretty much take care of the Tfcc injury. So this is kind of a gross answer to your question, sir. I hope it answers the question. But if you want, we can take some specific scenarios. For example, a Galeazzi fracture dislocation. You would first fix the distal radius first, and then look for DRG instability. Usually, with stable fixation, with accurate reduction, the DRG is stabilized. However, if it's still unstable, especially in pronation and mid-prone, but stable in supination, you just immobilize with an above elbow cast for 6 to 8 weeks.
Right. So, for the people who advocate ignoring these injuries, since you are a hand surgeon for a pretty long time now, so you must be getting these cases after the fracture has healed 1 year or 2 years post injury, and they may be presenting to you with some specific complaints about that. So, can you tell us more about this kind of ignored TFCC injury that present late?
Right. So more often than not, usually these patients present with weakness, pain, difficulty in lifting weights, difficulty in doing activities of daily living, such as driving, ringing. So that's how they present with. And they may also say that I feel a click, and that is usually the instability as the ulna dislocates from the sigmoid notch, and that is how they present with usually.
Right. Right. So, is there a problem with delayed repair versus the early repair in these cases?
Well, early repair allows you to maybe do a minimally invasive kind of procedure, and you're able to repair the native ligament back to the bone or whatever.
Right.
But chronic injury, you may have to resort to doing reconstructive procedures using tendon grafts, making tunnels into the radius and the ulna, weaving the tendon graft through. Also, it's kind of a complex and a complicated procedure that has a very steep learning curve. However, it does give you good results, no doubt about it, but it's just that you miss out on the chance of performing a primary repair. And then it's like a chronic ACL where you have to do a double bundle repair, for example, using a tendon graft.
Right. So, about the repair, which cases of TFCC injury will you not repair?
Central perforation, 1A, right?
Okay.
So that is the avascular part of the TFCC.
Right.
Then 1C also, not all 1C injuries need to be repaired. That is in the ulnotriquetral and the ulnolunate kind of aspects. I'll just very quickly make a small diagram, sir.
Yeah.
I'll share it on the video for just give me one moment.
Yeah.
So can you see this figure? Is it visible?
Yeah, I'll take the video on the center part so people can see it. Yeah. Now we can see it clearly once you put it up.
So can you see this picture that I'm
showing on this? Clearly.
So this is the radius, this is the ulna.
Right.
I've highlighted the TFCC.
Okay.
So imagine that this is the dorsal aspect of the TFCC.
Right.
The volar aspect. What are these vertical lines indicate the ulno-lunate and the ulnotriquetral layer. So they're connecting the TFCC to the carpus.
Right.
So this is on the volar aspect. So usually tears of this part, the dorsal radioulnar ligament, which you can see here,
right,
they are repairable. Okay.
Okay.
If there is a central perforation, like you see here,
right,
they cannot be repaired because this is an avascular part. You just debride it and leave it alone.
Right.
Again, not all injuries of the ulnocarpal and the ulnotriquetral ligament or the ulnolunate ligament, that is the 1C tears, okay, type 1C, C as in cat, okay. So even they can be just debrided, or you can do a thermal shrinkage and you leave it alone, okay.
Right.
1D is involving the insertion onto the radius, which is this part of the TFCC. Can you appreciate that?
Right.
Now, even this one, if the tear is more than 2 or 3 millimeters, then and only then you need to repair it. Otherwise, you shave it and you keep it, and then it usually heals on its own.
Okay.
So it's usually peripheral tears, okay, or avulsion from the ulnar styloid.
Right.
These are the injuries that we repair, and these are the most common injuries. In fact, again, just like rotator cuff tears, most times you would see a combination of injuries. It's not usually a single injury in isolation or a single pattern.
Right.
So you may see a peripheral tear along with a central perforation.
Right.
Or a peripheral tear with a radial tear. Okay?
Right.
So you address the major component of the injury when you do these procedures.
Right. So there is a question by Dr. Srijit Srinivasan. He is asking, yes, can we do an open repair if scopy is not available?
Of course you can do it. Of course you can do it. It's just that it's a very tight joint. You need magnification when you're doing these repairs, and you need very good assistance from your assistants for retraction so that you can see the joint very well. And usually these repairs should be done in supination, with the forearm in supination. So you have to do a little bit of gymnastics to be able to do a good repair. Okay.
Right.
So I'm always compelled to share an aphorism. If there is a technique that proves to be beneficial for your patients and has documented good results, you should learn and master that technique and use it for the benefit of your patients. So if you do not know arthroscopy, you should learn arthroscopy and then use it. Just a philosophical kind of thing, just to share that.
Right.
Right.
So what are the long-term effects of a TFCC that is left unrepaired, a tear that is left unrepaired?
Let me counter that question with a question for the audience especially.
Yeah.
There was a time, I'm sure, sir, even with your residency days and growing up, when we were residents, we were said ACL tears, nothing happens, just leave them, right?
Right.
There was not much available at that point in time. What happened to all those knees now? They develop arthritic changes, right? IDK as we call it.
Right.
Most injuries, pretty much like that. Tfcc injuries will lead to DRG arthritis in the long run. So they will develop arthritic changes, but it is a slow procedure. It doesn't happen, before 10 years.
Okay.
But they do develop arthritic changes, and then you have to resort to salvage procedures once arthritic changes set in.
Okay. So
I just one more thing, sir. I'm sorry to interrupt. This is gross instability patterns.
Right.
If it is just a central tear or a peripheral tear or a distal component tear with no instability, the only thing is these patients will continue to have pain that reduces with rest, and again will come on when they start doing routine activities or strength themselves.
Okay. Okay, I think we have covered acute TFCC in great details, and probably for chronic, we'll have another session with you for the chronic injuries. And so
I hope it was okay with everyone. It's a little bit of a niche topic, very focused. Nonetheless, it addresses a very misunderstood or a very ill understood area of the wrist joint.
Right. Right. Okay. Thank you, sir. Thank you very much for joining us so late in the day.
Thank you, sir.
Thank you very much.